Hello, everyone. I am here with Dr. Christopher Mashburn. He is a recent graduate of the UK pharmacy program, and he is a first-year resident at University of Cincinnati Veterans Hospital. And he has just accepted a second-year residency in their psychiatry division for psychopharmacology, which is a special interest area of his. I'm super excited to have him here, and thanks to all of you for sending him these questions. I'll go ahead and get started. Dr. Mashburn, I would like you to say a little bit about this notion that sometimes people talk about where they feel numb or like a zombie on their antidepressants. Is that real? What would you recommend doing about that?
Yeah, I've certainly heard that complaint. And again, I'm not super experienced compared to some of the pharmacists that I work with, but at least in my interactions with patients, with friends, people that I've talked to, it certainly does seem like feeling numb or maybe not feeling quite yourself is something that can happen. I won't say that it won't. Antidepressants can affect people in many different ways, and I have heard of that before. I guess technically a more scientific way of saying it, or something you might see in the DSM-5, maybe something called like affective blunting, where you seem less expressive, you have a more flat affect or flat expression or face. You don't show your emotions as much because you might not feel them as much. It's hard to say the best ways to fix that or mitigate that. Antidepressants and really any psychotropic medication affect people so differently. Like what works for me may not work for you. What may make me like flat or less expressive may not do the same thing to you. So ways that I've seen this problem, I guess, addressed in practice is reducing dose, potentially if a dose had gotten increased and the person started feeling flat, backing off on that dose has helped, or even switching medications. There are thankfully a few different options, especially for antidepressants, anti-anxiety medicines, and just because one doesn't seem to work for you, another might work better and may not make you nearly as flat. So certainly a good question. It's definitely something that I've heard of, maybe more so with mood stabilizers, that sort of numb feeling, but certainly can happen with antidepressants too, but there are ways around it. We can try changing the dose. We can try a whole new medicine altogether.
Thanks so much. The next question I wanted to check in with you about is drinking alcohol while taking antidepressants something that we can do safely?
Yeah, so like a lot of things in medicine, I would say it depends. How much are you drinking? Maybe even what are you drinking? What medicine are you on? In general, antidepressants like the SSRIs, SNRIs, certainly potentially have an interaction with it. If you drink alcohol, it might lower your tolerance a little bit to be on those antidepressants, might make you a little more sensitive to some of the effects of alcohol, which some people see as a benefit. But certainly something to look out for. It might make you a little bit more sensitive. Definitely have the potential for more sedation with it as well. Alcohol is a sedative. Combining that with antidepressants, which a lot of which can be sedating, can certainly make that sedation effect more potent, which may also be why your tolerance is a little bit lower on these medicines typically. That doesn't apply for everyone. One thing I would like to point out is that, let's say you're taking an antidepressant for depression, alcohol itself is a depressant. So drinking it, especially in excess, may actually make your depression worse. So while it's not necessarily a full-on chemical sort of interaction between the drug and the alcohol, physiologically in your body and mentally, it may still have an interaction. It may make your depression worse. So I'd certainly recommend in moderation with antidepressants. And if you are a person or you know someone who's on an MAOI, which thankfully most people aren't on anymore since they tend to be older drugs with more interactions, those can actually have more serious interactions with alcohol. Food and drink that contains tyramine can interact with those MAOIs and can cause really significant and severe blood pressure spikes. So some foods, drinks that have that in it are like aged soft cheeses. I think some wines have it. Draft beer has it. Fermented foods as well. So if you are on an MAOI, that can definitely have more of a severe interaction with alcohol compared to most of the other antidepressants. But that is a good question. I would recommend talking to your doctor if you do plan on drinking, and it's okay. I would recommend being very honest with your doctor too, because they can't help you if they don't know. But in general, probably make you a little more susceptible to the effects of alcohol. If you are depressed or even anxious, it can make those worse, especially if drinking in excess with those concurrent conditions.
Thank you so much. And I would like to add too, this is not something that you want to experiment with without some other trusted person in your company. And as Dr. Mashburn pointed out, it's really better to be honest with your doctor and get their advice about that to reduce risk associated with the effects of alcohol in general, much less with that counter interaction that could present itself. Safety first. Oh, the next question is, what are some side effects of taking mood stabilizing medications?
That's a good question. Again, I'm going to throw it back to that. It depends. It depends on what medicine you're on, which mood stabilizer you're on. Are you on valproic acid? Are you on lithium? Are you on Lamictal? Are you on topiramate? There are a lot of different medications, and one of the ways that we really do differentiate and help choose which medicines that we take are the side effects, potentially the interactions that they have, but some that stand out. Lithium, you can look out for some kidney problems since it is mainly excreted through the kidneys. Some people have issues with that. Thyroid. There are some monitoring parameters if you are on lithium. I have my thoughts on lithium. I think it's a very good drug. It's very effective. And if anybody has any more questions about it, I'd love to talk about it because it's, I wouldn't say my favorite, but it's definitely interesting to me. Topiramate can make people really tired. Brand name is Topamax. Some people call it Dopamax because it makes people so dopey and sleepy. Lamictal tends to be, or lamotrigine tends to be pretty well tolerated, but it is pretty unique in that you have to really slowly increase the dose of it. So you may need a pretty high dose, but it takes a long time to get to that dose due to a side effect of it called SJS, Stevens-Johnson syndrome, which is a really intense, really bad autoimmune reaction, which basically causes burns all over your body. It's a safe medicine. You just need to titrate it up really slowly. So that's something that's pretty unique for Lamictal. What is it? Valproate, valproic acid, divalproex, any of those valproic acid derivatives tend to be sleepy. Again, we do some drug monitoring for that too, checking valproate levels just to make sure that they're within safe ranges. We also monitor liver function with those as well, since valproic acid and its derivatives could potentially cause some liver damage. Again, it's safe if it's in that dosing interval, same as lithium. It just might need some more monitoring than some of the other drugs.
Sometimes people that I work with in practice have concerns about taking older drugs like lithium, and they're worried about the fact that it requires the lab work. What would you say to them?
Yeah, no, I mean, I think that's a very valid concern. Older drugs do tend to get a bad rap, but I would counter with saying that if we're still using them, they likely work pretty well, which is true. And just because a drug's old doesn't mean we don't have good data, doesn't mean we aren't still looking at it. So like lithium, there's still plenty of clinical trials going on with it right now, since it is used fairly often in practice. I'd like to raise the point that aspirin has been used for thousands of years. People used to chew tree bark to get aspirin out of it, or salicylate derivatives, and use that for pain control. So there are some drugs that we use even today that are technically thousands of years old. As far as the lab monitoring, I would definitely agree that is a little bit scary, and it does seem a little daunting. Not to mention it may be a little bit inconvenient for patients too. Thankfully, now that we've got some better tests, better understanding of the drugs, it's not as frequent as maybe it used to be, but knowing that, I have to be monitored, they have to check this because it could be dangerous, it would weigh on a person, and I don't blame them at all for taking that consideration regarding their drugs. I would say if it's working really well for them, getting that monitoring is, of course, really important, not only to make sure it's working, but to make sure that it's safe. I would say any drug can be unsafe. It's not just lithium or valproate that can be unsafe. Even SSRIs, SNRIs, tricyclic antidepressants, things that don't necessarily need monitoring, can still be unsafe. So older drugs, even though they are older, we might look at them as potentially older, dirtier. They're really well understood. I look at it as a benefit because we've had more time to get research, to accrue knowledge on them, to see how they work, how they interact with things, and build our knowledge based on them. So I wouldn't necessarily say that older means that it's worse. And certainly with lithium, I think we're even learning things about it today.
Thank you so much. So one of the things that I sometimes face in my work when I begin to introduce the idea of considering medication is people feel afraid because they focus on potential side effects, and they make comments like, the side effects sound worse than the problem that I'm having. So what is your stance on medicating issues as opposed to working to correct behaviors without the use of prescriptions?
Yeah, that's a really good question. I think that patient-directed care is certainly important, and doing what the person would like and what they're comfortable with is definitely important, especially for psychiatric care. However, I would argue that both therapy and medications play big roles in treatment for some of these diseases. For some diseases, therapy, of course, is first line because maybe some medications don't work as well. For other disease states, medications may be first line. But any time that you see any sort of psychiatric treatment, especially involving medications, therapy is right up there conjoined with it. If they are apprehensive about starting medications, which is completely understandable, I would say trialing therapy first, seeing if that helps, and then potentially looking at medications again down the line. I've seen that work well for patients where they tried psychotherapy for a few months, said, I'm not necessarily getting all the benefit I want, maybe we could try a medicine now. And it could be an ongoing topic during therapy sessions with their therapist, and bringing it up and asking their concerns, because certainly it does seem like some of the side effects we talk about might seem worse than depression, but at the same time, could it be the depression or the anxiety talking and getting excuses for not taking medicines, or giving reasons to not take medicines, which, again, I'm not saying that patients are acting against their best interests, but sometimes it can cloud your judgment if you're not in a good mental health space, and you're not able to think maybe clearly and see that maybe some of the side effects, while they are really bad, are not nearly as common as the benefits from the drugs. And again, patients are allowed to make their own medical decisions. I respect that a lot. If they just want to pursue therapy, that's fine too. But I do think medicines can make a difference. They're not going to fix everything, but they're really going to help augment that psychotherapy and give maybe the little push to get things better. They make the highs a little higher and the lows a little less low. Not the end-all be-all, but certainly can be a great complement to therapy. And being aware of those side effects is important, but at least acknowledging that they won't necessarily happen to you. Some of them may not be very common at all, and combining them with therapy will really get you the best benefits from your medicines.
Thank you so much. This is a little bit similar in that I think there's some anxiety around that process of finding the right medicine. This student noted that she understands that sometimes you can not experience benefit from things like an antidepressant for 2 weeks. And her question is, if you feel like you're not getting that benefit and with your doctor's support, you're ready to try something different, is there danger in, switching that over before that drug might be out of your system? Or is there a waiting period where you should stop taking one, take a break, and take the new thing? What are your thoughts?
Yeah, no, that's a great question, and that's very pharmacy oriented, actually. So yeah, let's say theoretically I started an antidepressant. I'm 2 weeks in, I don't feel a benefit. You really see maximum benefit at around 6 to 8 weeks. But if you're not feeling anything by week 2, that's certainly a good reason to talk to your doctor and think about switching. Switching from one medicine to the other is definitely a big point of interest for pharmacy, for medicine in psych. Trying to find the best ways to switch between antidepressants or whatever medicines you need. Oftentimes, what we'll do, and same for antipsychotics as well, is what's called like a cross taper. So you bring your original medicine, the one that's not working, and you start bringing that dose down, and at the same time, you start your new medicine, you kind of bring that dose up. So one's going down, one's going up. They kind of meet in the middle for a little bit. So you still have that old one on board starting to get off, and you have the new one starting to get on. So it's not always done, but for some drugs, it works better than others, especially ones that tend to have like short half-lives that wear off a lot quicker. It can be better to try to do that taper, because suddenly withdrawing that medicine may lead to some side effects like withdrawals from the SSRIs. So doing that cross taper, you bring the dose of the old one down as you bring the dose of the new one up, kind of can help alleviate some of those side effects. That's typically what is done when switching between medicines. Some, it's more important to do that than others, like fluoxetine. That one, Prozac, is actually, it has a long enough half-life that they say it self-tapers. So that one, they tend not to worry as much about trying to do a cross-taper, since it lasts so long in your body, it kind of self-tapers itself as you get on a new one. Other ones, like paroxetine Paxil, have a really short half-life, and people tend to benefit more from those tapers. But yeah, that's a good question. Switching between the medicines is frustrating. It can take a while, since the antidepressants take a long time to kick in, and it can be a little scary. What's the best way to transition between them? And that's where doctors come in and help develop that taper plan, and that's where pharmacy comes in too, bringing some of the knowledge that we have that the doctors may not necessarily work with all the time, and we work with them in tandem to come up with the best taper plan, the best transition plan between your medicines.
Thank you so much. So one of the things that I just want to reiterate, and correct me if I'm wrong, you said the maximum benefit from some of these medicines is actually not seen for 6 to 8 weeks. Okay.
Yeah. So for most antidepressants, especially SSRIs, SNRIs, you'll start to see benefit around the 2-week mark or so. But to really see the full benefit of them, most clinicians do say it's about 6 weeks or so to see the full benefit of those antidepressants.
Thank you. I feel like anecdotally we hear different numbers, so it's really good to hear that from an expert, because I have heard people say, well, I've been taking this for 3 weeks and that's long enough. It should be working now. Some people say 1 month is long enough. So I really appreciate that tie into science. Okay. This is the last question that I'll ask you. As a consumer, are there questions that you're uncomfortable answering as a pharmacist?
Is there any elaboration in that?
Sure. Absolutely. So what I'm getting at here is, how can my students feel more comfortable talking to their pharmacist or encourage others to feel more comfortable? So an example would be if someone's taking an antidepressant and they feel like it may be having a side effect in their sex drive, could they say something to the pharmacist about that and get feedback?
Yes, absolutely. And it depends, again, on like your health system, how it's set up, how close your pharmacist is necessarily with your doctor, because some of these conversations may be better to have with your doctor since they may be the ones making the therapeutic changes. But I would say any pharmacist worth their salt would be more than happy to talk to you about it. I know that I really appreciate when patients come to me with questions, or when a professor comes to me with questions about pharmacy. I would say, yes, it can be daunting. It can feel awkward to talk to somebody, but I can't think of a question that I would be necessarily uncomfortable with at least fielding. Now, there are some things, like if they're asking, maybe dose adjustments or medication management that really should be done by the doctor. I may not be comfortable giving recommendations because I cannot prescribe or make differences, changes in therapy. But as far as questions about medications, sexual side effects, mood side effects, you name it, I think any pharmacist should be more than willing to answer those questions for you. And again, like I said, I understand it can be a little daunting. It can be intimidating. One thing I would like to say is a pharmacist is the most accessible healthcare provider that there is. That is a fact that is, at least for this country, most people live within 5 miles of a pharmacy or less. So you should be able to, talk to your pharmacist, because really we can serve as your first line to talk to your doctor, to be a sort of liaison to you about your medications. And of course, we're here to answer your questions. We honestly, at least based off of myself, my coworkers actually enjoy answering some of those questions. So again, it can be intimidating. It might feel a little bit awkward, but I would certainly say any pharmacist should welcome any questions that you have. And if they're not able to answer it, they can probably point you to someone who can, or give you some resources to look into it as well.
Thank you so much for being willing to share this time on what is Thanksgiving Eve. I really appreciate the information and look forward to sharing this with my students. And I will follow up with them if they have further questions. Is that something you'd be comfortable fielding?
Yeah, absolutely. If they want to come up with any other questions after this, you can put it into an email and send it to me, and I can address them and try to get them any answers that they want.
That's wonderful.